Hi, my name is Rajesh Kiswani, and I'm an Associate Professor of Medicine at Northwestern University Feinberg School of Medicine in Chicago, Illinois. On behalf of my co-authors, I want to thank the editors at Clinical Gastroenterology and Hepatology for selecting our manuscript to discuss in this video. The genesis of the study comes from our group's interest in ensuring that our patients receive the highest quality of care. Unfortunately, in the United States, we have no good way currently to identify whether providers are performing high-quality ERCP, as a registry does not exist. As ERCP is a higher risk procedure than most gastrointestinal endoscopic procedures, it's imperative we identify at least some ways to determine which providers may be providing higher quality care than others. There has been a great deal published in the surgical literature about the relationship between provider and institutional volume and outcomes for diverse procedures such as pancreas surgery or esophageal resection. Less is known about the relationship between ERCP volume and the outcomes of interest, namely successful procedures and adverse event rates. Due to the limited available data, our group elected to proceed with performing a systematic review and meta-analysis of all available literature on the association of ERCP volume and outcomes. Our literature search identified 1,264 citations, of which 13 met inclusion criteria. The first thing we noted from this, the definition of low volume varied widely between studies. For example, some studies identified a volume of less than 25 as a low volume for an endoscopist, whereas other studies identified a volume of less than 156 ERCPs as low volume for an ERCP endoscopist. Endoscopists who were identified as high volume in their studies were significantly more likely to achieve ERCP success than low volume endoscopists, with an odds ratio of 1.6 in this meta-analysis. High volume centers were twice as likely to achieve ERCP success when compared to low volume centers. It's important to note at this point that we found marked variability in what is defined as a successful ERCP in the available studies. For example, some studies reported that any patient who needed percutaneous biliary drainage as an unsuccessful ERCP, which is obviously a limited definition of an unsuccessful ERCP. In contrast, other studies utilized the need for a repeat ERCP within 7 days as the definition of an unsuccessful ERCP. With these limitations in mind, in total, our data showed that low-volume ERCP endoscopists and low-volume ERCP centers are less likely to provide and perform successful ERCP. With regards to adverse events, we did find that high-volume ERCPists were less likely to have post-ERCP adverse events compared to low-volume ERCP endoscopists. However, this finding did not extend to high-volume centers, where there was no significant difference in adverse event rates after ERCP between high-volume and low-volume centers. So it's very reasonable at this point to say, what do we do with this information? Again, in the absence of a national registry on ERCP providers, there is very little data on how ERCP providers perform in the United States. Therefore, healthcare organizations that wish to provide ERCP are required to utilize surrogate markers of quality to determine which and how many providers should be performing ERCP at their institution. What can be done with this information? Well, healthcare organizations can understand that there is a volume-outcome relationship, and instead of employing 4 to 5 low-volume ERCP endoscopists, they can employ 1 to 2 high-volume ERCP endoscopists to ensure that ERCP is being performed at high quality. Although the volume-outcome relationship will not hold up for all providers, it is the best we can currently do. And therefore, the other thing we must do is encourage our societies and our payers to support a national registry so that we can better measure the outcomes of ERCP to ensure that we're consistently delivering the highest quality care to our patients. Until that is done, we must ensure that ERCP is performed by high-volume providers and in high-volume centers to reduce any potential morbidity from ERCP. Once again, on behalf of my co-authors, I want to thank you for your interest in our manuscript. We'd be happy to correspond further if you have any ideas on how to further this work. Thank you.